Hey everyone, so the topic I'm going to be talking to you about today is dysphagia secondary to flaccid dysarthria. Just to provide some background, dysarthria is impaired muscular control to the speech mechanisms. So it's characterized by muscle weakness, decrease in reflexes, and progressive weakness with muscular use. Specifically, flaccid dysarthria is characterized by a muscle weakness. Dysphagia is difficulty with swallowing, characterized by the impairment of one or more of the stages of swallowing. So therefore, this affects swallowing safety as it increases the likelihood for penetration and aspiration of the food and liquids that we use. Flaccid dysarthria is caused by damage to the lower motor neurons. So this is damage to the cranial and spinal nerves. This is considered the final common pathway. So basically it disrupts the neuronal impulses that supply the nerve muscles for respiration, phonation, articulation, resonance, and so forth. This damage can be caused from many factors such as surgical trauma, brain, laryngeal, or chest surgery, stroke in the brainstem. So if the artery is blocked, these neurons experience necrosis. Disease also such as myasthenia gravis, which is a neurodegenerative muscular disease characterized by muscular weakness. And as energy expenditure is increased, the exacerbation of the muscle is further broken down. Well, the exacerbation of the muscle further breaks down the muscle. So there are bulbar and peripheral lesions. Bulbar lesions occur on the nuclei of the cranial nerves, and peripheral lesions are damage the axons of the cranial nerves. So tying this all in together, there are signs and symptoms of dysphagia as a result of flaccid dysarthria. So as we learned in class with the flaccid dysarthria, there are certain cranial nerves that are damaged which impact our speech. Taking this from the other perspective, there are certain cranial nerves that are damaged, those same cranial nerves, but they can also impact our swallowing to impair it, to increase our risk for penetration, the material either sitting on top of the vocal folds or going beneath the vocal folds, and aspiration, the material actually going into the airway. So let's just take a few of these cranial nerves and break it down from the beginning to the end. Cranial nerve 5 is the motor branch responsible for mandibular movement, for the movement of our jaw. If this is impaired, this can make the person have inefficient mastication and decreased range of motion because their jaw is not strong enough to effectively and efficiently chew the food chew the food. Therefore, this increases the risk for oral residue because there will be material left in the mouth after the swallow. Cranial nerve 7 innervates the lips and it can cause facial paralysis. So therefore, the person might have decreased labial seal, anterior loss, food pocketing and drooling, which again can cause oral residue. And we can also look at cranial nerve 12, which is responsible for innervating the tongue muscle. So if this is damaged, the person may present with decreased lingual movement, range of motion, decreased gag reflex, decreased ability to form a cohesive bolus, and a decreased AP transport. All of this together can cause oral residue, pharyngeal residue, and aspiration before and after the swallow because, again, the tongue is not strong enough to move the food efficiently and effectively from the oral cavity all the way into the pharyngeal. So signs and symptoms that the material is actually penetrated or aspirated would be if the person had a wet, gurgly vocal quality, multiple repetitive re-swallows, coughing, and throat clearing. So how can we assess if a person has dysphagia secondary to flaccid dysarthria? Well, there are many things we could do. First, it's very important to take a multidisciplinary approach. You need to look at the person's medical record before you even see them. Look at their CT scans, look at their MRI, their brain imaging to see if there actually is a lower motor neuron involvement. Also see if anything is comorbidly existing with the flaccid dysarthria. Another thing a speech therapist does is a clinical dysphagia evaluation. This is a bedside exam where the therapist gives the patient an oral peripheral exam to see how the muscles in their mouth are working, and also they give them PO trials where they change the liquid consistency and the food consistency based on how they're tolerating it, if they're showing any signs or symptoms of aspiration. A more objective way to assess this is a modified barium swallow, where all the food and the liquids used in the CDE are used here, but they're laced with barium. So you can see them on the x-ray to see if they're actually going in the right way and seeing how the mechanisms are working together. Also, you can do a perceptual assessment. Is the person hypernasal? Do they have imprecise consonant production? Are they breathy? Are they monopitched? Do they have nasal emission, short phrases? These can all be indications that they do have a flaccid dysarthria. And this is an example of an oral peripheral exam of a client with flaccid dysarthria. As we would expect, the strength and function of the lips and tongue, as well as the jaw and cheeks, are decreased. How can we treat this? We can do oral motor exercises to increase the strength of the muscles used in swallowing. So the oral phase, we can increase mastication, lingual control, jaw stabilization with these exercises. And we could also look at the pharyngeal phase, increasing the airway closure and protection, increasing hyalorhyngeal elevation and excursion, and increasing the base of tongue retraction. We can also do compensatory strategies. This is for people who are maybe not eligible for oral motor exercises secondary to a comorbidity, that they're not able to do the exercises, such as myasthenia gravis, where it's a neurodegenerative muscular disease that energy expenditure decreases their ability to move their muscles. So a modified diet would be giving them a diet consistency that is safe for them to swallow, whether it be a puree, a mechanical soft for an advanced diet, also liquids, thickening the liquids if the thin liquids are going into their airway. Next are postural changes, which again changes the course of the bolus movement so that it doesn't go into the airway. So this can be using a head tilt or a chin tuck. And here are my references.